So I'd like to welcome Dr. Brady Heward, who is the co-director of clinical affairs and assistant professor of psychiatry at the UVM Larner College of Medicine, as well as a member of our UVM CORA Clinician Advisory Board, who is here today to introduce our speaker, Dr. Jackson. So Dr. Heward, I will turn it over to you.
Thank you, Lucia. Yeah, it's my great honor to introduce you to Dr. Peter Jackson, a good friend and colleague. Dr. Jackson is also a co-director of the clinical affairs of UVM CORA and an assistant professor at the University of Vermont Medical Center and College of Medicine. Dr. Jackson specializes both in child and adolescent psychiatry and in addiction psychiatry. Dr. Jackson attended medical school at the University of Utah and then went on to complete his general psychiatry residency at University of Michigan before moving to Boston, where he went to the Harvard MGH McLean program for his child and adolescent fellowship, followed by a Harvard fellowship in addiction psychiatry. We then were lucky enough to recruit him up to the University of Vermont, and he's working at the University of Vermont clinically in both addiction and inpatient child psychiatry. Dr. Jackson is also a member of both the American Academy of Child and Adolescent Psychiatry and the American Academy of Addiction Psychiatry, where he serves on in both organizations on the committees working on adolescent substance use. And Dr. Jackson has written and teaches about and does research on emphasizing the role of parents and family members in the prevention and treatment of substance use disorders. And he previously presented a community round series on multi-generational approaches to prevention and treatment of substance use disorders. And today he's going to talk to us more about addressing stigma and bias in the treatment of substance use disorders in clinical settings. Dr. Jackson is a fantastic clinician, a great colleague, and a good friend, and I'm pleased to introduce him, and please join me in welcoming him.
Thanks so much, Brady. That was very, very nice of you for the introduction. I'm thankful to the CORA team, including Dr. Sigmund, who's sort of the leader of our team, and so grateful for Nicole and Lucia and Nellie for all their help helping us get ready for the webinar today. As mentioned, we're going to be talking about stigma and bias. So I wanted to start off and say giving a talk about stigma and bias is a little bit challenging because I'm sure as I talk today, I'll say several things that are unfortunately stigmatizing and that contain bias. One of my favorite teachers would often start his teaching by saying that his most immediate audience is himself. And I would like to echo that same sentiment, knowing that coming to this type of talk, we all have room for improvement. The objectives today is hoping that we can recognize the impact of bias and stigma, consider strategies to decrease it. Some of that will come through improving our understanding of addiction and substance use disorders through a disease model. Hopefully we can increase compassionate feelings within ourselves and build confidence to increase compassionate care in the organizations which we're part of. And as we do all this, we're going to look particularly at the cultural implications of stigma towards substance use disorders in rural communities. I wanted to start off with a story. And so this came on the very first day that I entered the third year of medical school. I bushy-tailed, having spent a couple years in the beginning of my training, basically in the classroom. So lots and lots of classroom time, but not too much hospital time. So I get into the medical team. I started my rotations on the internal medicine floor, people hospitalized, and I got assigned a patient that I was going to, help the team care for. He happened to be a young adult male, sort of in the same demographics as myself. He was married, he was a new dad, and he had been admitted to the hospital lots of times. And the team was working with this large differential diagnosis on what was keeping him sick. And being a medical student, you know, you're sort of honing in on the science of it, the differential diagnosis, thinking, you know, all these things. And what people had thought about is autoimmune diseases, potential cancers like leukemia, lymphoma. He was having just continued infectious processes, and people didn't know what was going on. I can't remember actually exactly sort of what the microbiology was. I can't remember a lot of it actually. I think that anxious, excited brain, you know, didn't put down enough memories. But what I do remember is after a few days of us trying to care for him and take care of him, walking into our team rounds the next morning, and the chief resident coming in really upset and saying this. And I couldn't figure out what was going on for a little bit, but he walked in extremely upset about what was going on with this patient and what had happened on the sort of late end of the overnight shift. So early in the morning before we all came in, one of the nurses had walked in and found this individual with a syringe and with some crushed opioids, injecting into the portacath that he had placed because of needing IV antibiotics. He was self-injecting crushed Percocet with a syringe. And what I remember most about that situation is how angry members of the treatment team felt, and watching a serious shift in the care that was given to this individual, where early on people had seemed to rally scientifically, so curious. We're trying to figure out, you know, what's going on, why has he been staying so sick? And when this new piece of information came into the puzzle, members of all disciplines within the team seemed to just really drop their compassion. I felt so under-resourced and so under-prepared to help out. But I remember this happening. And I wanted to start with that story because it was incredibly impactful for me. So my question as we start this talk is, are we then preaching to the choir? We have people here that have come to a talk about stigma. I assume that means we have an audience and a presenter, I hope, who don't want to have negative stigma impact our care. So before you leave the webinar and say, well, I would never say that about somebody, I would never just shut down my care as soon as I found that out about somebody, what I think we all need to be humble enough to recognize is that our probably most dangerous or damaging types of bias and stigma are the ones that we don't know that we have. And so I wanted to point out just one piece of information from our basic needs assessment that one of our teams from CORA did. Basically a big survey asking people about sort of what's going on with addiction treatment in their communities. So one of the questions said, please select the top 3 provider barriers to treating opioid use disorders in your practice. The least commonly selected answer was provider stigma. But interestingly, the most commonly selected barrier was the concern about medication diversion. And to me, that doesn't make a lot of sense. That doesn't make a lot of sense. And then if you asked about the 3 patient barriers to treating opioid use disorders, stigma was second only to transportation as the most commonly selected response. So here was a large group of providers saying, essentially, I'm giving some artistic license here, but it feels like we're saying essentially, we don't have any stigma. The patients definitely perceive stigma, but it must not be our fault because we don't have any stigma. As you know, I'm exaggerating a little bit, but I thought that was really interesting. And so I'll include myself in the group in saying we all need to work on this. As we think broadly, I'd like to help us think about multiple types of stigma. So perceived stigma, somebody's understanding of how others may act towards them or feel about a certain individual that has a trait or identity. Anticipated stigma is sort of the thinking forward, expectations of what stigma may contribute to your experience in the future. Internalized stigma, we're thinking about self-stigma is another way to kind of think about that. And then experienced stigma, clearly, I think this story that I shared on the medicine wards would be experienced stigma, sort of discriminatory acts or behaviors. But I want to think broadly about that. And then thinking about these other forms of stigma, so stereotypical beliefs. Someone with an addiction is such and such. And if you don't think you have any stereotypical beliefs, again, we need to be mindful about that, but maybe you have some attribution beliefs, thinking about, is somebody in control, or why did this happen to them? Or some expectation beliefs about their chances of recovery. We'll talk a little bit about these. Or at a minimum, maybe you think, oh no, they're doing fine and it's not their fault and we're gonna help them through this and they have a good chance of recovery. But would you wanna live next door to them? That's another aspect of stigma, thinking about the social distancing and stigma. As we think about stigma in rural settings, we've looked through this as a team, myself individually and as a team, and tried to pull as much of the literature out as we can. It's a small amount of literature, but I think I just want to recognize that talking about stigma as it applies to rural settings, we need to be careful to not stigmatize rural settings. I think one of the papers that we looked at says rurality is dimensional rather than categorical, and I think that's really important. I live in a town with 1,600 people and no stoplights, so pretty rural, but I've lived there for just less than 4 years, and before that I lived outside of Boston. Before that, I lived in a town with 4,500 people and 2 stoplights. And before that, I lived in suburbia, basically. And so am I a rural person because of where I live now? So thinking about this is important for us. Important for us to not further stigmatize rural areas. Some of the studies that we see about stigma as it applies particularly to rural areas do show some significant differences. One of them showed a significant relationship between masculine norms and self-stigma of help seeking. So that in itself can sometimes be a stigmatizing attitude, but this was found to be twice as strong in rural areas compared to urban areas. And then another study found that self-stigma was significantly higher in older adults in rural settings compared to urban settings. Then there are some other studies that have tried to assess the differences here between rural and urban and haven't found significant differences. That's that study from 2018. We don't need too many studies to just tell us that this is common, but I wanted to reference one. This was a study done by the World Health Organization back in the early 2000s, basically trying to look and rank what conditions across medical treatment generally are most stigmatized. And drug addiction, the term that was used in that study, was ranked number 1, and alcohol addiction was ranked number 4 compared to all other conditions. So talking briefly about the impact that stigma has, we'll just do a couple of slides on this and we'll emphasize it throughout the talk. There's less treatment seeking, which is a major tragedy because we know that of people who are struggling meeting criteria for a substance use disorder, estimates are around 10 or 11% of them are actually receiving treatment. There's poor prognosis, there's a higher likelihood to not complete treatment, there's lower self-esteem, individuals feeling less empowered to make change, and then this social alienation that we talked about, decreased opportunities for employment, housing, connectedness with others. And in this way, inequity can stack on top of inequity and making basic life necessities an additional challenge for these individuals. Impact on professionals, so lower individual regard, we'll talk about that a little bit, not just thinking less of people, but I think thinking about people less often are both problems. Decreased motivation amongst professionals to provide treatment, feelings of dissatisfaction, powerlessness, resentment, all of these resulting from, in surveys, feelings that professionals have towards individuals struggling with substance use disorders, that they're unmotivated, that they're manipulative, that they might be violent. And then we see significant decreased likelihood at times of offering certain types of care, including pain management for someone struggling with a substance use disorder. I think Dr. Heward and I and others have found that often in our work, we end up advocating as often, if not more often, for our patients to receive pain treatment rather than having to tell providers to be cautious about pain management because of that stigma. So we want to review a little bit some of the ways that this stigma can happen and can persist. And one of them is through our language. I think Teresa is going to revisit this in the webinar in a few weeks, but this is really important. The language that we use matters a lot. So when we identify somebody who's using substances as being either clean or dirty, that is so stigmatizing, has such a negative connotation about who that individual is. And so these are some of the terms here, and there's lots of resources available at the end of the slide that talk about language, and they can give you and the people that you work with some tools and some words to try to avoid. That language has really deep roots, and it's widespread, and it's in high places, including our, our agencies, our federal agencies that are asked to address this health problem. So, presidents of the United States, in working to prevent the consequences of substance use problems, use language like this: public enemy number one. A lot of people think this should have been called a public health crisis number one, or the war on drugs, sort of the language there, identifying it, that makes us sort of feel like it's us against them. Our agencies like SAMHSA and NIDA both have the word abuse in the title. And so a rebranding effort, I can only imagine that's challenging and financially difficult, but we need to work hard to try to avoid this type of language in our treatment. We also need to use person-first language, not only in our substance use treatment, but in our treatment of all conditions. So if someone is not a diabetic or an asthmatic or a schizophrenic, it's a person with those conditions. And same thing with substance use. We try to use terms like that, an individual with a substance use disorder. When I'm on the other end of the phone, taking a consultation from the emergency room, for example, and my job is to decide whether somebody needs to be admitted to the hospital psychiatrically or not. I think it really does make a big difference how that person is portrayed to me in language, especially if I'm not there in the hospital. It might be late at night. I'm taking the call from home. The language is really all that I have to understand who this person is. Here's a study that just provides emphasis to what I've just been talking about. So our terminology influences our attitudes. So first sentence: Mr. Williams is a substance abuser and is attending a treatment program through the court. This then goes on to describe some of the aspects of Mr. Williams, and he's had a return to use, having some difficulty. Mr. Williams has been a substance abuser for the past few years. He now awaits his appointment with the judge. Versus the only change that you'll see in the next phrase. This was a study done by John Kelly from Massachusetts General Hospital. The next phrase: Mr. Williams has a substance use disorder. Same exact paragraph. He's had a substance use disorder for the past few years, and now he awaits his appointment with the judge. So Mr. Williams was introduced to professionals in this study, was introduced to professionals with only that change in the description. And this was a study given to a wide variety of professionals, many addiction providers. 65% of the respondents had a doctoral level degree in this study. And so here are some of these statistically different response frequencies, what people believe about Mr. Williams. And again, I'm going to go up. All of the difference is that in one paragraph, he is called a substance abuser. And in the next paragraph, he has a substance use disorder. And this changed the perception, significant difference in these statements. What people believed about Mr. Williams: his problem is caused by reckless lifestyle. He's responsible for causing his problem. He should be given some kind of jail sentence to serve as a wake-up call. His problem is caused by the poor choices that he made. He could have avoided using alcohol and drugs. I believe that he'll do something violent to himself. And I believe that he will do something violent to others. All of those responses and others, if you want to look at the study, showed a significant difference, a higher response rate of this pessimism and these stigmatizing thoughts, just based on that one word or that one aspect of the sentence, whether he's a substance abuser or has a substance use disorder. Another part of stigma that can happen for us, I think, is when we create false dichotomies, when we can't be cognitively flexible. As a psychiatrist, we use cognitive behavioral therapy all the time to try to help us avoid all or nothing thinking. And so here's some of the dichotomies that I think can get us into trouble. One is someone's either ready or they're not ready. And these are dichotomies that I think we're improving on. So this kind of gave way to the stages of change model from Prochaska and DiClemente, pre-contemplative, contemplative, preparation, action, maintenance, those different stages. That's important for us. Another one is that you're either abstinence-based or you do harm reduction. And I think we can get in this trap that basically if you don't do it my way, there's not value or purpose in doing anything at all. So we need to recognize that there are individual paths of recovery. And Teresa is going to talk a lot about that in the webinar in a few weeks. Another false dichotomy is that you either have the expertise to provide the treatment or you don't. And that goes along with the last bullet there, that treating substance use disorders is too scary. You have to have this extra special license and you have to get a waiver. And for some reason, for buprenorphine prescription, they called it an X license. I mean, to me, that just sounds scary. You have to get an X license. So we need to be cautious. Another dichotomy that I think we are hopefully overcoming in general is that we used to think you have to take care of your substance use disorder or we can't treat your anxiety or we can't treat your depression or your bipolar disorder. And now we're finding better ways to do co-occurring treatment. I wanted to just highlight this again, circling back to it, the results that we see in this study by Kane and colleagues from 2019. I think that was important. This was particularly done in low and middle income countries, and it was done all over the world. This big review of stigma-related bias, or sorry, substance-related stigma and bias, and how it impacts care. Again, studies from all over the world, poorer health outcomes, less treatment seeking, less engagement in primary care, less clinical providers educated in that field. I'm going to own briefly and just say that for me, when I went through medical school, to make the decision to become an addiction psychiatrist, I had to overcome like a mountain of individual stigma and sort of societal stigma to make that decision. I remember so clearly when I shared that with a neighbor, a really nice neighbor, they came to me and said, but you were going to be a surgeon. And I told them kind of how my interests were changing in medical school. And they said, but you're so normal. I remember that so clearly. It felt so weird to hear that, but I just wanted to emphasize for that point with the star that I myself experienced that in really intense ways to decide to pursue this as a field of expertise. Again, less education, less full-time employment, and the social isolation. And I just wanted to emphasize this is worldwide. In this study, countries from every continent were represented. So it's all over the place. Some of the things that we notice at times when we talk with rural populations, and hopefully we'll have some time to discuss this, but word of mouth information about whether compassion exists in the care center in a rural area can spread very quickly. There's a higher likelihood in rural areas that someone will be connected through multiple roles or settings. That can lead to a decreased risk of sort of decreased privacy in rural areas. So when you go in to meet with somebody, they have a high likelihood to be your partner's provider. They might also be your teenager's provider. They might be your best friend's provider. They might be they might be the provider for your child's school teacher. There's more degrees of interconnectedness. I experienced that myself just the other day in a small town when I needed to go and get care. Somebody that I hadn't met before knew everything about me when I walked in the door. So there's also, I've heard patients say all the time, there's nowhere else to go. So the options for treatment, if there's stigmatizing attitudes, if there's not a compassionate care, I've heard people come and express concern about this, but then say there's nowhere else to go. It's not like we have 2 clinics in our small town. There's sometimes a culture in rural areas of self-efficacy, self-sufficiency. And this is something that's also been studied, that those individuals may feel that they should be able to take care of themselves generally, including with something like a substance use problem without help. One study, this study from 2015, showed that stigma sort of stigmatizing attitudes against substance use disorders were more common in primary care than they were in specialists. That feels like a little bit of a no-brainer based on some research that I'll show you later. But this is something that we have to be aware of, because if specialists have less stigma in their offices, that's great. But what do you do when there's no specialists around? We have to work to continue to decrease stigma in rural areas. Another thing that I think can be particularly pertinent in thinking about rural areas is that these areas have been found in some studies to have an increased access to legal substances in homes compared to urban areas. The opposite is true often for illicit substances. But this is an area where I think in rural areas, it's important not to focus on a single path to recovery. Sometimes that path might be very rigid and say, I can't help you with your substance use problem with opioids if you're not willing to completely swear off of any tobacco products and alcohol products and anything else forever. That might be a harder ask in a place where there's an increased access, or it's more common to see legal substances in individuals' homes. So what do we do about stigma? I'm hoping that we all will be able to take some pearls away from the talk to sort of take back for ourselves and to take back to the clinical areas that we work in. To think about this, I wanted to talk about two things, cause and controllability. We'll sort of get to some of the practical take-homes, but thinking about cause and controllability can help us. So first, cause. Why does addiction happen? That is a good question for us to just ask ourselves, a rhetorical question. Ask yourself, why does addiction happen? Because one of the main areas where stigma abounds is basically, you chose this, and so this is your fault. And so talking about cause to start, about half of the risk for substance use disorders is believed to be genetic. That's a large estimate, but we have lots of research about that. This is a similar level of heritability to other conditions like type 2 diabetes or prostate cancer. We know that there are some individuals with a genetic tendency where substance exposure is just going to be more risky for them. I talk with families all the time thinking that if 100 kids go off to a high school party and are exposed to substances, around 15 of those 100 kids are going to have an experience that is more intense than all of their peers. It might be a stronger pull, it might be a more sense of euphoria, and we know more and more about why that is. We won't go into the details here, but we balance this against prognosis, and we'll talk about that a little bit. We know in this question of whether it's nature or nurture, we know that it's both. So genetic contribution and environmental contribution both have an impact. This study, I think I referenced in the last community webinar that I did, but this is basically looking at a parent who gives you genes, a parent who only contributes to your environment, like a stepfather, and a parent who contributes to both your genes and your environment. And we see that both genetic influence and environmental influence are very strong, with a slightly higher, in this study, slightly higher strength of the genetic influence. We think about adverse childhood experiences. Everybody on this webinar, I'm sure, has heard of the ACEs study and all the branching studies that we're learning from that. But as you look at adverse childhood experiences, the most common household challenge, as they originally looked at this, was substance use in the home. And you see substance abuse is used in that term. That's from the study, but it's very, very common. And so you think, the child psychiatrist in me thinks about the fact that we can really decrease our stigma if we're willing to at least think back and say, what were the contributing factors to this person developing this challenge with substances, including how early they were exposed to substances, which we have lots of science about. So thinking, again, we're talking about cause, and if we can think about the cause of a substance use disorder in this multifaceted way, this slide comes from a study by Dr. Biederman, who's down at Mass General, just thinking about sort of developmental contributions towards substance use disorder. You think about genetic predisposition, you think about social adversity and stressful events, and then access to substances. How, when you started having all this social adversity or this trauma in your life, how easy was it for that individual to find a substance to try to take away the pain that they were feeling? Did they have depression? Did they have anxiety? What was the parental modeling? What type of peer influences do they have? So when we think about cause, looking back on that with a compassionate approach can be very helpful. Thinking about controllability. So let's say we overcome that cause stigma. And so we kind of say, okay, well, I won't blame this individual that it's just all their fault and they chose this. Sorry that happened to you. But then sometimes I think we say, okay, but now can you just change? And so thinking about controllability is another area where stigma can be very high. And we think about this balance between you can control this versus you can't control this. And on all of these areas, I'm going to ask us to be mentally flexible and to not think all or nothing. So when we think about controllability, this is where understanding substance use disorders in a disease model has been very helpful. This paper I would highly recommend, very useful paper by Nora Volkow in the New England Journal of Medicine back in 2016. And this basically goes through, I think, I love the science, but I'll tell you in some ways why we might love the science more than the actual individuals love the science. But this goes through and shows us that in the beginning, voluntary use can become impulsive use over time. That the initial feeling of euphoria, wow, that felt nice, I enjoyed that feeling, transitions over time to, in the end, you're escaping dysphoria rather than feeling good or having euphoric feelings. Withdrawal symptoms go from feeling reduced energy, not feeling great, all the way to anxiety, depression, intense restlessness. I'm sure you've seen this in your work. And then the anticipation goes from, oh, I'm looking forward to that, to an obsessive planning that can happen. And we have good science that tells us where in the brain this happens and how it happens. And so thinking about the controllability, when we think about it from a disease model, that can be very helpful for us. There's a balance, an important balance here. If you sort of say addiction is a problem, and John Kelly, again, who did the research about substance abuser versus person with a substance use disorder, has done some research about how providers feel if we think of this as a problem versus a disease process. And so thinking about some balance. When people see it as a problem, they may have some pros to that of thinking, well, then it's fixable and it's controllable. But some cons, large cons there, is that it can be seen as a moral failing. If you had enough motivation, you just change. The disease model, the pros there, compassion for both causality and controllability and less blaming. But the cons, if we're not careful, can be prognostic pessimism, something that can't be fixed, to something that's too ingrained, or something where your heritability has just doomed you to have this condition. So it's really important for us to find this balance, incorporating the disease model. But I like this article. It's in the references, so I didn't put the name by it. I don't have to know why it snows. I just have to shovel it. So every once in a while, I'll get really excited about the science behind it, and I'll start, with an adolescent or maybe somebody who's starting drawing pictures of brains, and that can definitely help reduce stigma about cause and controllability. But we can't do that to the point of forgetting that we just need to focus on effective treatment principles. We have a lot of science that sort of shows us how to find this balance. Ask yourself, how many attempts at recovery does it take for somebody to recover from a substance use disorder? I've heard all sorts of answers to that question. And I just read recently in preparation for this, a study that sort of referenced this. How many tries does it take? I think when I was first starting in, somebody said, well, it takes nine tries on average, 9 tries on average to go through rehab. Question, what is a try? Another question, so what do you do on try number 1 if that's going to be completely useless to have somebody walk into a rehabilitation center or to a treatment program for the first time and to have this attitude, well, this is their first time, so not much we can do until they're here on their 9th time. This recent study showed that sometimes we have looked at the mean number of recovery attempts instead of the median, meaning we're looking at the average and being sort of pulled by maybe some of these outliers, where the most common number of attempts might be closer to 2. And so that can give us, sort of help us fight against this prognostic pessimism. I think that's useful in the study references there. So again, what are some of the things that we can do about this challenge? I'm going to sort of start from, I guess, sometimes we talk about soft skills and practical aspects. We're going to start a little bit with practical aspects and work toward the soft skills, all of which I think are really important. So one of the practical things that we know is increasing contact between an affected population and the larger population can help decrease stigma. We need to know who these people are. We need to know individuals who have substance use disorders. We need to work with them. We need to find ways to provide treatment. We need to find ways to provide people in education settings to have experiences meeting and providing treatment and care for individuals with substance use disorders. That sort of goes back to some of what is believed to contribute to specialty clinics having less stigma than general practitioners or family practice or primary care settings, because they do it all the time and they know these people sort of more intimately. So that's one thing that we need to do, both in treatment and in training, is increase the contact between providers and individuals receiving treatment. Another thing that we need and are moving towards is parity laws for coverage of these conditions, that there's insurance coverage and treatment, just like for any other condition. We need to improve our communication standards. We talked about the language. We need both person-centered language and person-centered treatment. We also need to work towards widespread access to treatment. This no wrong door approach. There's no wrong place to ask for help with a substance use disorder. There's no wrong provider to talk with about needing support. Nobody wants to be sort of quietly shipped to the back door of the hospital, and yet that happens too often in our hospital settings. The substance use treatment clinic is sort of tucked away in a corner somewhere, and you have to sort of find your way there without much noise. We're getting better at this. We're getting better at access to substance use treatment in primary care, access to substance use treatment starting in the emergency room. We do this here at the University of Vermont, and I think it's becoming more and more standard of care. If somebody goes to the emergency room with a substance use problem, with an opioid use disorder, for example, they can be started on buprenorphine there and have an appointment here with us in our clinic with like the very next business day. So this widespread access to treatment, there's no wrong door. Going on to other potential ways that we can help is, again, understanding this disease model of addiction. We've sort of looked at that. Understanding heritability, that there is nature and nurture in the onset of substance use problems, and then balancing both of those things with having optimism about prognosis, having optimism about these being conditions from which people do recover, they do get better, and having accurate data about that. Which again, that study from John Kelly sort of pulls into question this idea that it takes tons and tons of attempts before somebody makes progress. That's not helpful. Sorry about that. So recovery-oriented treatment. This is a way that I think is really important for us to care for people across all settings, is to make sure that we're treating an individual and focusing on their goals of recovery rather than our own outcomes. So when we're treating somebody for anxiety or somebody for depression, somebody with a substance use disorder, making sure that we're looking at their level of functioning and not just their GAD-7 or their addiction severity index. That's really important. So when we're working with people in general, but particularly with a substance use disorder, I think it's often, we're looking at, well, did you make all your appointments? Let's look at your urine drug screens, and we're looking at sort of these data points. But we need to not forget to start treatment with the questions like, what types of things would you like to get back to? What will life look like for you? What will be the indicators of wellness? And ask questions, not like, what did your urine drug screens look like, but did you get to go out fishing with your grandson yet? Those types of things that really bring people and their lives to the forefront of treatment. We also need to tell stories. There's an organization called FAVOR, the Faces and Voices of Recovery, a national organization that's trying to sort of bring these stories to the forefront. We need to facilitate communication about hard things, make things talk aboutable, as one of my mentors said. I like that phrase. And in making things talk aboutable and telling stories, I don't know about those on the call, but I have so many times where I'll meet somebody and tell them what I do for work. They ask what I do for work. I tell them, they get sort of this gloomy weight about them, and they seem to almost sort of want to apologize to me. I'm so sorry you do such a hard job. And the conversations, I think, can be so rich to just say, for all of us to say, I love what I do. It's a wonderful work. I love the people that I work with. It's such, just that, and help people realize that this isn't too heavy, too scary, that it's good to do. And then I think it's important for us to ask the individuals that we're working with about their experience in our clinic, in our own office, even in a one-to-one. Invite them to give us feedback. Will you let me know if there's something that I'm doing or something that I'm saying or something about the way that our clinic is set up that makes you feel uncomfortable or that makes you not feel welcomed into treatment. Now getting to maybe some more kind of softer aspects of how we overcome treatment and bias, asking ourselves honest and introspective questions. Questions, like we talked about earlier. Yeah, maybe I'm not going to go in and use foul language about somebody who's had a substance use disorder, but how would I feel living next door? That type of thing. Owning and recognizing our countertransference, a psychiatric term, basically sort of how we feel about someone we're working with, and then working with the team. I'm so grateful. We have a really awesome team in our clinic. And sometimes I think we need to just ask for help with the team. I'm feeling these negative feelings. Help me out. Help me sort of talk through it. And then supporting your team also by being confident enough to give them feedback, or maybe ask hard questions of the team. Carl Rogers was somebody who I learned about when I was first thinking about working in the field of mental health and working in the field of substance use treatment. And he coined this term, unconditional positive regard. I find it so powerful. And somebody who I've liked learning about and reading. But I wanted to just reference this one quote. So this primary theme of unconditional positive regard, which he also calls a person-centered approach, he said that it can be briefly stated, it is that the individual has within him or her vast resources for self-understanding, for altering one's self-concept, attitudes, and self-directed behavior, and that these resources can be tapped if only a definable climate of facilitative psychological attitudes can be provided. That really lines up well with the motivational interviewing approach. I think this is really, really important to sort of pair these ideas, and something that I feel I often need to sort of go back and remind myself about. The first two chapters of Miller and Rolnick's motivational interviewing textbook are chapters that I've read a few times. The second one is the spirit of motivational interviewing, and talks about these principles: partnership, evocation, meaning you're bringing from somebody, you're helping them find answers to change, compassion, and acceptance. really powerful things for us to take into our work, our treatment, our practice, and to talk about with our teams. We wanted to list several tools and resources. There are a lot of really good pages with resources that we can take back. And I did want to leave some time for question and answer. As we start into that, I wanted to remind us, evidence-based practice includes this Venn diagram, these three things. It includes the empirical research of what we've learned. It includes our own clinical experiences, and it includes the patient's values and preferences. And when we get in the center of those three things, I think is when we're giving the best care. Part of the reason I wanted to reference this is because on this call, we have an immense amount of clinical experience. And so hopefully this can be a robust discussion for the time we have left.
Thank you so much, Dr. Jackson, for that extremely informative presentation. And I know there's a lot swirling around in all of our minds right now. And so I want to get a couple of questions out there. So we'd like to open up the floor for questions and comments. Please feel free to put them in the chat or unmute yourself and ask them out loud. Again, I'd like to welcome Teresa Vizina, who's with us, who's the Associate Director at Vermont Cares, into this conversation. So Teresa, please feel free to jump in if you feel like you can contribute to some of the questions asked. I'm going to start just from the ones that were in the chat during the session. One from Laura Dewey, and Laura, please feel free to hop in if you want to speak to this more. But Laura said, I would also love to hear your thoughts on supervision. As a licensed clinician prior to licensure, and even with licensure, supervision is either required or best practice. I'm curious to why this is not an expectation for all providers, nurses, and any other provider teams. I realize that I can't change this, but it's just a thought. Do you have thoughts about that, Dr. Jackson?
Yeah, thank you, Laura. That's a great question, and thanks for attending. I think that would be an awesome thing to mandate. Some places where I've worked before actually do mandate that, at least early on in your career, that you have some sort of peer supervision. So it's no longer sort of I'm training you, but we're working together. I will say that after I finished my training and there was no longer sort of this formal supervision, there's a group of peers that I gather with on a regular basis. And we try to talk with each other about challenging clinical situations. I also think our supervision in some ways comes by working in teams. I think it's just so important and pertinent that we work in teams. And once we're sort of in these teams, there can be sort of a hierarchy that has some necessity in training. But at a certain point, as we work in teams, especially if we work respectfully in teams, we don't sort of see ourselves at the top or at the bottom or at a specific place in the team, but we have this honest and open communication with each other. So hopefully people that are sort of seen to be leading a team have hopefully the humility and the confidence to invite feedback. And I think that supervision sort of comes peer to peer. I think it's a great question and something we need to do more of.
And then one more from the chat is from Amy Sullivan. She says, Dr. Jackson, do you think that adding a required substance use disorder education component to medical school training would have an impact on reducing stigma in the medical field? Is that even a realistic goal to think that schools would engage in that sort of education?
Yes, and yes. And there is a required component, I think, through most aspects of medical training. There's sort of benchmarks, benchmarks through the ACGME that need to be maintained. So the answer is yes and yes. I don't know as much about training in other disciplines. I know more about training through medical school and through residency programs. But there is an aspect of sort of mandated training in this regard in most programs, and where there aren't, I think absolutely there should be, because it helps make us, well-rounded providers.
Great, and I see a raised hand Drew or Bodhi, would you like to go ahead? I'll unmute you here. There you go.
Yes, my name is Drew, and I, I recently read Drug Use for Grown-ups by Dr. Carl Hott from Columbia. And one of the things he was saying that since we should not talk about abuse, but we should talk about more about drug use, and the disease model of addiction doesn't really focus on healthy drug use that many people do, and they don't come out because of stigma. So he was kind of saying that, jumping into disease model as if drug intake is always an abuse has perpetrated stigma. So I see that you are, we should not use these terms that you say, but at the same time you endorse the disease model. Can you I would like to hear your opinion on it.
Yeah, thank you, Drew. That's a great question. Thank you for bringing that to light. I haven't read that. I haven't read that book, but I think it's an important perspective. And I think it is important for us to realize from a psychiatric standpoint, we have sort of these diagnostic categories. We do need to be careful to sort of identify the severity of a condition when we're treating it. That would apply to all conditions. And I think we do need to sort of accept the idea that any use doesn't equal a substance use disorder. Diagnostically, that completely makes sense. There's these 11 different criteria, and if you meet a certain number, then you have a use disorder that's mild, moderate, or severe. But you have to meet at least some of the criteria to even have a mild use disorder. So I think that's a good point, Drew. I appreciate you for bringing it up. And I think that we do need to be careful, because that's another area where stigma can get in our way. I referenced that slide about rural areas where smoking or alcohol may be more common in homes. And so if you go in there and say any smoking and any alcohol equals a nicotine use disorder and an alcohol use disorder, you have to be careful. And our clinical interviews are really important. And then we bring it back to that person-centered approach. Is this getting in your way? How is it impacting you? You're not just checking, diagnostic criteria. You're trying to understand whether and if this is a problem for somebody. So I don't know if that helps, Drew, but thank you for bringing that up.
Thank you.
We have a lot of questions in a limited amount of time, so I'm going to try and get through a couple of these before we wrap up. Lori wrote in the chat, substance use disorder and opioid use disorder are often separated from mental health issues. This distinction seems to further separate substance use disorder as a mental health diagnosis, which is my untrained understanding. Do you think the separation further stigmatizes SUD as a unique or different mental health condition, or a substance use disorder not truly a mental health condition?
That's a really good question. Thank you also for asking that. These are wonderful questions. I think you're going to have varying opinions about that as you hear from people. But I have, and I'm an addiction psychiatrist, so my path into this treatment came through a full psychiatry residency, and then a child psychiatry fellowship, and then an addiction fellowship. And so, but I think it's clearly not a good idea for us to think of substance use disorders only as mental health conditions. I think it's very common that they co-occur with mental health conditions. And research shows us this. I think it's very common that they may be more likely to result when somebody struggles with a mental health condition, but it makes no sense at all for us to say that's to lump them in that category only. And this has been problematic in many ways. One of them is insurance coverage, these quote unquote carve outs where we're going to insure you, but for your mental health stuff and maybe for any addiction or substance use problem, someone else is going to take care of that. It's not good. It doesn't make sense. And lumping them in together as just one category, one definable thing, I think is not wise.
Thank you. And I'll just say we have so many questions in just a moment here. So I'm going to, Ed, I saw your hand raised if you want to unmute and briefly ask a question, and then we'll have to wrap up here.
Great. Thanks a lot. Dr. Jackson, excellent presentation. I have always admired you. I'm so happy that you brought up Carl Rogers. Just to mention that one of his concepts is the importance of the genuineness of the provider and the idea of congruence. So if a provider is harboring stigma, they either are forced into a position of being incongruent, which people generally with substance use disorder, having been a very large number of them, having experienced early adverse experiences, come into the treatment setting a little bit more sensitive and a little bit more prone to early stress reaction. So if you have a therapist that's either incongruent or somehow mildly expressing stigma, that particular client, that particular patient that has a proneness toward early stress reaction or early fear reaction is very likely to withdraw from counseling. So it seems to me, with the knowledge that we have today, that stigma and knowledge of stigma and self-examination should be built into our ethics training, because it just seems unprofessional to not focus on this particular aspect with people that we're sending out to the field to work with one of the most vulnerable populations in America. So I would like to hear you. Would you like to comment on that, please?
I think it's a really good point, Ed. I guess I would just concur with you about that and this idea of genuineness. I have no critique of it. I think it's a good point to add to the conversation. So thanks for bringing it up.
Okay, thank you, Doctor.
And I'm sorry to cut us short. I know there are a lot of questions still in the chat and lots of thoughts going on in folks' brains. I will do my best to follow up via email for all the unanswered questions and connect you with Dr. Jackson. If you're able to fill out this poll, we would really appreciate your feedback. And then Dr. Jackson, if you wouldn't mind just advancing to the next slide. I also, before we all log off today, to emphasize our next session, again, hosted by Teresa Vizina, that we spoke about. I put the registration in the chat. We would love to see you at the end of April to continue this conversation about stigma, harm reduction, and best practices for approaching substance use. So thank you all so very much for joining us today. And we look forward to continuing this conversation. And thank you very much, Dr. Jackson, for such a fantastic presentation. So take care, everyone.
Bye-bye. Thank you, Lucia.